In today's PowerPoint presentation, we will be talking about the anatomy of the knee joint with few of its clinical correlations. This slide shows the contents of today's lecture. You can pause here and see whether the content that you want is present in it or not. The knee joint is the largest and most complicated joint of the body, which is formed by articulation between the femur, tibia, and the patella. The two femoral condyles, the lateral and the medial, they articulate with the corresponding condyles of the tibia to form synovial condylar joint. Next is the patellar surface of the femur, which articulates with the patella to form synovial plane gliding joint, right? Knee joint is unique in sense that it is made up of, in turn, it is made up of two different sorts of joint. One is the condylar joint formed between the femur above and tibia below, and the second one is the joint formed between the patella in front and femur on the back, right? And this is the synovial plane gliding joint. This diagram you can see, this is the lower end of the femur, this is the lateral, and this is the medial femoral condyles. This silver or bluish color, this is the articular surface of the femur. This is the tibial bone below the lateral condyle and the medial condyle of the tibia. While this hanging down, this is the patellar bone, right? So the first joint is the joint between the femur and the tibia. This is the first subjoint within the knee joint, and the other one is the joint which is formed between the patellar surface of the femur and the under surface of the patella. Talking about the capsule of the knee joint, it is attached to the margins of the articular surfaces and it surrounds the posterior aspect and the sides, right? Just like the four walls of a room, uh, the capsule, it is present on lateral wall, medial wall, and posterior wall, but the anterior wall, it is different, right? Uh, it is absent in front, and here it permits the synovial membrane to pouch upward and forward to form the suprapatellar bursa, right? So out of the four walls of the capsule, the anterior wall, it is deficient, and through it the bursa is the synovium is pouching forward and superiorly to form the suprapatellar bursa. Also, there is a small opening in the posterior surface to allow the tendon of the popliteus muscle to emerge. The posterior wall is not deficient as such, but there is just a small opening, and this is for the allowance of the popliteus tendon to emerge out, right? Uh, Now, the three walls of the capsule, the lateral wall, medial wall, and the posterior wall, they are strengthened by the neighboring muscle, the tendinous expansion from the neighboring muscles. The strength from the sides are provided by expansions from the tendons of the vastus lateralis and the vastus medialis, right? Vastus lateralis from the lateral side and vastus medialis from the medial side. Then from the back, the strength is given by expansion from the tendon of semimembranosus muscle. And this tendinous expansion is given the name of oblique popliteal ligament. So we have three walls of the capsule, and to which the support is given by vastus lateralis from the lateral side, tendinous expansion from the vastus medius from the medial side, and by oblique popliteal ligament from the posterior side. This diagram is the cross section of the knee joint at the level of the minescii. These moon-shaped or C-shaped structures, these are the minescii of the knee joint that we'll be discussing in a while. This is the outermost covering the skin. Then this is the yellowish subcutaneous tissue, right? Then this green outer ring, right? This is representing the deep fascia of the thigh extending below into the knee area. Then the inner circle, this is representing the knee joint capsule. Okay, here you can see this is the semimembranosus tendon, and then this is the tendon expansion from the semimembranosus tendon, and this is known as the oblique popliteal ligament. Ligaments are those connective tissues which are meant to connect two bones with one another, right? And these are the structures which are responsible for the strength of a joint, right? Knee joint has got two different types of ligaments. One category is the extracapsular ligament. As the name indicates, these will be present outside the capsule of the knee joint. And the second category is the intracapsular ligaments. These will be residing inside of the capsular cavity. There are four different types of extracapsular ligament: the ligamentum patellae, lateral collateral ligament, the medial collateral ligament, and the oblique popliteal ligament. And then there are two intracapsular ligament, which are the crossing or the cruciate ligament. One is the anterior and the other one is the posterior. So we have got the anterior cruciate ligament and the posterior cruciate ligament. In this diagram, this is the anterior view of the knee joint. Here you can see these two crossing structures forming an X shape, right? These two are the cruciate ligaments, okay? The anterior cruciate and the posterior cruciate ligament. These two are the intracapsular ligaments of the knee joint, while the rest of the four, the extracapsular, they are uh, the first one, the lateral collateral ligament, this one on the lateral side, then the medial collateral ligament connecting the femur with the tibia, medial collateral ligament. Then we have this ligament hanging downward, connecting the patella, uh, right patella with the tibial tuberosity. This is the patellar ligament, and last one, this is the oblique popliteal ligament on the posterior side, right? Next are the minescii of knee joint. These are by minescii we mean these cup-shaped structures, right? These cup-shaped structures, which are basically made up of fibrocartilage, right? These are two cup-shaped sheets of fibrocartilage, which have got a thick peripheral border, which is attached to the joint capsule. And then there is a thin and concave inner border forming the free edges. As you can see in this diagram, uh, this is the lateral meniscus, while this one is the medial meniscus. You can see this is the outer border, right? This is the outer border, while this one is the inner border. The inner border is concave, the outer one is the convex border, right? Then the outer border is thicker one, while the inner border, it is thin, right? Then in the capsule, which is not given in this diagram, but the outer wall, it has got the outer boundary, it has got attachment with the capsule of the knee joint, both the lateral and the medial meniscus, right? While the inner borders of both the menisci, they are lying free. Their upper surfaces are in contact with the femoral condyles, while their lower surfaces are in contact with the tibial bones, right? And they have got two main functions. The first one is to deepen the articular surfaces of the tibia to receive the femoral condyles. And also they act as cushions, right? Each meniscus is attached to the upper surface of the tibia by anterior and posterior horns. Now this point is noteworthy that the medial meniscus is also attached to the medial collateral ligament, right? Medial meniscus is different from the lateral meniscus in different aspects, and one of the differences is that the medial meniscus is attached to uh, medial collateral ligament, and that's why it is relatively immobile. And the clinical significance of this attachment is that it is more prone to rupture, right? As it is fixed, so it can easily be crushed and is more prone to rupture. Here you can see this is the medial meniscus, while this one is the lateral meniscus. This is the anterior horn attached to the upper surface of the tibia, while this is the posterior horn attached to the upper surface of the tibia, right? Then you can see the uh, uh, medial meniscus, which is more wider and larger relative to the lateral meniscus. Also, the medial meniscus, it has got attachment with the medial collateral ligament, and the lateral meniscus, it is free from the lateral collateral ligament, right? Now the synovium of the knee joint. The synovial membrane is the membrane which is present in all the synovial joints, and it is a secretory layer which is secreting a fluid known as the synovial fluid, which is responsible for decreasing the friction of the joint wall movements. It lines the capsule. It is attached to the articular margins, and then it outpouches above anteriorly to form suprapatellar bursa. Right, as previously discussed in the under the heading of capsule, the capsule of the knee joint, it is deficient anteriorly, and through that deficiency, the synovial membrane of the knee joint, it pouches forward and upward to form a bursa known as the suprapatellar bursa. Also, this extends right. So the suprapatellar bursa extends beneath the quadriceps muscle, 3-finger breadth above the patella. The above bursa, the suprapatellar bursa, it has got support by a muscle called the articularis genus muscle, right? Articularis genus muscle, and it is a small portion of the vastus intermedius muscle, a muscle of the anterior compartment of the thigh, one of the 4 quadriceps femoris muscle. Also, the synovial membrane at our pouches below, posteriorly on the posterior surface of the popliteus to form the popliteal bursa, right? Previously discussed under the subheading of the capsule of the knee joint. In the posterior wall of the capsule, there was a small hole which was permitting the popliteal ligament, right, to go through it. And through that deficiency, the synovial membrane, it is outpouching to form a bursa called the popliteal bursa. The synovium is reflected forward from the posterior surface of the capsule around the front of the cruciate ligament, so that the cruciate ligament lies behind the synovial cavity and are not bathed in the synovial fluid, right? Here you can see this pinkish layer. This is representing the synovium of the knee joint, right? This is representing the synovium of the knee joint, which is lying inside of the capsule of the knee joint. As you can see, it is attached to the lateral wall, right, of the capsule, then to the posterior wall of the capsule. But as it reaches the area of the cruciate ligaments, it is reflected anteriorly, and then it takes a U-turn and goes posteriorly, right? So that these two ligaments, the cruciate ligaments, they are lying posterior to the synovium, and they are not within the cavity of the synovium, right? So they are not bathed with the synovial fluid, okay? In anterior part, the synovial membrane is reflected backward to form from the posterior surface of the ligamentum patellar to form the infrapatellar fold. The free folds are termed as Eller fold, right? Now, bursa. These are the structures which are basically similar to that of the synovium, and are in most cases they are formed by outpouching of the synovium of the proper joint cavity, right? And they are found wherever the skin, muscle, or the tendon that are rubbing against the hard structure of the bone, okay? Now in knee joint, 4 bursa are situated anteriorly and 6 are situated posteriorly. 10 important bursa are present within the in relation to the knee joint, in which 4 are anterior and 6 are the posterior. Now it is noteworthy that the suprapatellar and the popliteal bursa, right, which both of these which were formed by the outpouching of the synovial membrane through the deficiencies in the walls of the capsule. These two bursa, they are always and always communicating with the joint cavity, right? While the semi-membranosus bursa, it sometimes communicates, while sometimes it doesn't communicate with the joint cavity proper. Okay. Now the anterior bursa are named as suprapatellar bursa, prepatellar bursa, And the last two are the infrapatellar bursa, in which one is superficial infrapatellar bursa, while the other one is the deep infrapatellar bursa, right? So suprapatellar bursa, prepatellar bursa, superficial, and deep infrapatellar bursae, right? In this diagram, you can see this is the sagittal section of the knee joint. This is the femur bone, this is the tibial bone, this is the patella. The first bursa, which is in front of the patella, uh, is called the pre-patellar bursa, right? This is the pre-patellar bursa, the one given in green color in this diagram, right? Then the two bursae, which are situated lower than the patella, right? These two, they are the infrapatellar bursae, in which one is superficial. This one, this is a superficial infrapatellar bursa, while the other one, this is the deep infrapatellar bursa. And the third bursa, which was found by outpouching of the synovium in anterior deficiency of the capsule, and is communicating with the joint cavity proper, right? This given in this bursa, which is given in the pink or reddish color, right? This is the suprapatellar bursa. Suprapatellar, as the name indicates, it is present superior to the patellar bone, right? So we've got four anterior bursa: the suprapatellar bursa, prepatellar bursa, superficial infrapatellar, and the deep infrapatellar bursa. Now the posterior bursa, they are number one, the popliteal bursa and the same membranosus bursa, right? These two are the larger one and the more famous one, and other are related to the tendons insertion of the biceps femoris muscle, tendons of the sartorius, gracilis, and the same membranosus muscle, right? And beneath the lateral and the medial heads of the gastrocnemius muscle. Okay, so popliteal and semimembranosus, which are the larger and more well-known and important bursae on the posterior side. This is the popliteus bursa. This is the popliteus muscle, right? This cut, this is the, which is cut down, right, into two. This popliteus muscle and the bursa, which is present just below the popliteus muscle. This is the popliteus bursa. Okay. And then this is the same membranosus muscle and the bursa, which is lying below the same membranosus muscle. This is the same membranosus bursa. Now the nerve supply of the knee joint. It is from all the major nerves of the lower limb, right? All the major nerves of the lower limb, they are contributing to the innervation of the knee joint. Okay, we have the nerve of the anterior compartment of the thigh, femoral nerve, which gives genicular branches to the knee joint. So it has got innervation from the femoral nerve. Then we have the nerve of the lateral compartment of thigh, the obturator nerve, which also innervates the knee joint, and then the nerve of the posterior compartment, and then the nerve of the rest of the lower limb, the sciatic nerve, right, which divides into common peroneal nerve and the tibial nerve. These two are also innervating the knee joint. So we have all the major nerves of the lower limb that are contributing to the innervation of the knee joint. The movements which are possible at the knee joint are flexion, extension, medial, and the lateral rotation. So we have four different types of movements that are possible at the knee joint. Flexion is made possible by the flexors of the knee joint, right? The flexors of the knee joint, the muscles that are situated on the posterior aspect of uh, uh, the posterior aspect of the thigh, right? Extension is made possible by the quadriceps muscle, which are the four muscles of the anterior compartment of the thigh. Medial rotation is made possible by the sartorius muscle, the gracilis, and the semitendinosus muscle. While the biceps femoris, it is responsible also. It is responsible for the flexion, but it is also responsible for the lateral rotation of the knee joint. This is a minor mistake in this slide. These are not the extensors, but these are the flexors, the muscles on the posterior aspect of the thigh. These are the flexors of the knee joint. So the heading should be the flexors of the knee joint, right? The muscles on the posterior aspect of the thigh, right? The biceps femoris, the semimembranosus, which are well known with the name of hamstring muscles, hamstring group of muscles. They are responsible for the flexion of the knee joint. Then the muscles of the anterior component of the thigh, the quadriceps femoris muscle, they are responsible for the extension. This is not flexion, extension of the knee joint, right? The muscles on the anterior aspect of the thigh, they are responsible for the extension of the knee joint. Anterior to the knee joint related are related is the bursa, the prepatellar bursa. While posterior to the knee joint, we have the popliteal artery and vein, popliteal lymph node, tibial and common peroneal nerve, and muscles forming the boundaries of the popliteal fossa. So simply we can say that the popliteal fossa with its contents, they are in relation to the in posterior relation to the knee joint. Medially, the knee joint has got sartorius, gracilis, and semimembranosus muscle on its medial side, right? We can memorize it by the mnemonic SSG, right? Special services group. On lateral side, we have got the biceps femoris muscle and the common peroneal nerve. Now, it is one of the important topic, the locking and unlocking of the knee joint. The locking of the knee joint happens during the last stages of the extension when a person is standing up. What occurs in locking is the medial rotation of the femur. It occurs as a space available at the lateral condyle of the tibia is being used up by the lateral condyle of the femur, right, during the extension. What happens in extension is that the femur, it rotates medially upon the tibia, okay? And therefore, the lateral femoral condyle that acts is an axis for the medial femoral condyle to rotate backward, right? The lateral femoral condyle, it acts an axis or fulcrum, and the medial femoral condyle, it rotates backward, right? The medial femoral condyle, it rotates backward. So you can imagine that the knee joint, it will, as a whole, the femur, or the thigh, it will, as a whole, rotate medially, right? This movement is aided by the oblique pull of the ligaments of the knee joint and contraction of the quadriceps muscle, right? The ligaments that are pulled taut when the knee joint is locked in place during standing, right? When the knee joint is flexed, it is unlocked. The unlocking is just opposite, right? It is unlocked by the popliteus muscle through the lateral rotation of the femur, right? So in locking of the knee joint, the femur is rotated medially, right? Is rotated medially upon the tibia, while in unlocking, due to the pull of the popliteus muscle, the knee joint is rotated laterally upon the tibia, and the knee joint unlocks, right? Here you can see these are the last stages of flexion, while this is the full extended, this is the last stages of the extension, while this is the full extended knee joint, okay? Here you can see, due to action of the quadriceps femoris muscle, the this is the this is the uh, femur bone, which is rotated medially, right? And the knee joint, the space available here, this is fully occupied by the condyles of the femur, and the femur, the knee joint, it locks. While unlocking of the knee joint, it is made possible by, or it is initiated by the pulling of the popliteus muscle. So the muscle responsible for the unlocking of the knee joint, it is the popliteus muscle, right? When this muscle contracts, the femur, it will rotate medially, right? Sorry, it will rotate laterally. And when the femur rotates laterally, the ligaments, they will be loosened and the knee joint will be unlocked. Next are some of the clinical correlations. The strength to the knee joint, it is uh, provided by the ligaments the lateral and the medial collateral, and also the cruciate ligaments. These four ligaments are responsible for the strength of the knee joint, and it is aided by the tone of the muscles that are surrounding the knee joint. Okay, anteriorly the quadriceps muscle, and posteriorly the biceps femoris muscle and other muscles. Right. Meniscal injury of the knee joint. We have studied uh, already that out of the two menisci of the knee joint, the medial and the lateral meniscus, right? The medial meniscus, which is relatively more fixed compared to the lateral meniscus, medial meniscus is a larger one, and is also got attachment with the medial collateral ligament. That's why it can easily be crushed between the femur and the tibia, and it is more prone to rupture, right? Talking about the ligaments, the medial collateral and the lateral collateral ligament. Uh, the lateral collateral ligament, it is more prone to rupture, right? As you can see in this scenario, the rugby player, which is this one, which has got a direct impact from the lateral side of the knee joint. If if this occurs, there will be abduction of the abduction of the tibia, and will lead to the outstretching of the medial collateral ligament. Hence the medial collateral ligament, it is more prone to rupture. Okay, this is the end of slideshow. If there is any query in your mind, you can ask me in the comment section below. Thank you very much for your patience.